Hello, everybody, and welcome back to Emergency Medicine Quest. In today's video, we will be talking about WBC disorders. Before we continue, make sure to like, share, and subscribe to the channel for more such content. Let's dive in with a quick recap. We know that different WBC cells have different functions. So, neutrophil is the most predominant type of WBC seen in 40 to 60% of our body, and it is the first responder to any bacterial infection, but it can also be seen in inflammation. Then we've got lymphocytes, which are present in 20 to 40%, and we see them usually in viral infections or chronic inflammation. We also have got monocytes, eosinophils, and basophils, which are seen in atypical infections, parasites, allergies, etc. We have two big categories to talk about. We have leukocytosis and we have leukopenia. If we start with leukocytosis, which is defined as WBC count of more than 11,000, but not all leukocytosis is infection. So if we see leukocytosis with neutrophil, this is what is called as the left shift. We can see left shift with infection, specifically bacterial, but we can also see it if the patient is well appearing, does not look sick. Then we can see it in a patient with steroid use or with stress response. If the WBC count is elevated accompanying lymphocytes, then we should think about viral infections, or we should also think about CLL. If the WBC count has predominantly eosinophils, then we must think about parasites, we must think about allergies. But what happens if the WBC count is more than 100,000? This is what is known as hyperleukocytosis, and it is a medical emergency. It can cause leukostasis, which leads to metabolic abnormalities, coagulopathy, and multi-organ failure. So we have to bring down the WBC count imminently, and we do that with the help of chemotherapy. So drugs like hydroxyurea help us bringing it down. The other entity is leukopenia, or decrease in WBC count. Now it has many causes like viral infection, certain chemotherapy drugs, autoimmune diseases like lupus, rheumatoid arthritis, and bone marrow suppression secondary to aplastic anemia, malignancy. It is often interchangeably used with neutropenia or decrease in neutrophil count. So, absolute neutrophil count less than 1500 is considered mild neutropenia, less than 1000 is moderate, and less than 500 is severe. Add to this presence of fever. This is what we call febrile neutropenia. Neutropenic fever is a life-threatening oncologic emergency. So in these cases, we start them on broad spectrum antibiotics ASAP without waiting for the cultures, and obviously we consult Heme or oncology for admission. Now let's say we're in the ED, we get lab report for a patient with WBC that has come out looking like a phone number. Let's talk about conditions that look like that. Chronic leukemias, or the silent killers. So in adults, we can have CML, which happens because of Philadelphia chromosome mutation, something that we know from medical school. And the age that it generally affects is 60 years. Now, CML has three phases. It has the chronic phase, in which 50% of the patients will be asymptomatic, but the other 50 will have GI complaints like abdominal pain, decreased appetite, nausea. It has the accelerated phase, in which the patient has abnormal bruising, petechiae, bone pain, and finally it has the blastic phase, in which it gets converted into AML or ALL, which is why CML is so dangerous. So the clue for CML is extreme leukocytosis And we manage CML in the emergency department with hydration, leukapheresis, and allopurinol. On the other hand, we have CLL, which is the most common leukemia in patients who are 50 plus years of age. And with increasing age, there is an increased risk of developing CLL. These patients come with lymphadenopathy, which can be so bulky to the point that it can cause airway obstruction or renal obstruction. So, the signs and symptoms of CLL is sudden anemia, jaundice, pallor, increased susceptibility to infection. Any ALC count more than 5,000 in adults should tip you off towards CLL, and the treatment in these cases is chemotherapy. So, the key takeaway from this lecture is if there is WBC disorders, consider three things: A, B, C. A is for antibiotic, B is for blasts, and C for consults. Antibiotic for febrile neutropenia, blasts should tip you off towards acute leukemia, and consults for hematology or oncology. Next time you see a patient with a WBC count of 40,000 in a tired looking 70-year-old, do let me know what will be your move. Drop down your answers below and stay tuned for more Rosen's rapid recaps.